Hello, everyone. Welcome to my talk today. I'm so thrilled to be here to share with you some of the research that's ongoing in the hospital and some future trajectories of interventions that we are working on. As Ms. Mabel said in the chat, please feel free to type your questions as they come. I am glad to answer questions as we go, but hopefully there'll also be time at the end for any questions you have. And also feel free to email me afterwards if you have ongoing questions. So today, the talk I'm so excited to give is The Power of Us, Understanding the Role of Family and Health Disparities. Again, my name is Dr. Patricia Roberson. So we all live in Appalachia here in Knox County, and we're all so familiar with the gorgeous views that we are so lucky to see. These beautiful valleys, river valleys, stretching up and down the Appalachian regions, the amazing mountain views. This is a picture of House Mountain, which is right next to me in the north end of Knox County. We're so lucky to be in this area that is just breathtaking, especially in spring and fall, in my opinion. But as we all know, these breathtaking views harbor a dark secret. We are among the nation the highest in breast cancer mortality and complications, highest in stroke, COPD, opioid misuse, tobacco use, alcoholism, diabetes and obesity, depression and anxiety. And we also know that these high rates, also HIV, and maternal and infant mortality, and these high rates of these health disparities are only exacerbated by the decades of devastating poverty in our region, the critically low number of hospitals, particularly in our rural areas, and the percentage of primary care providers throughout the state. And this is also most commonly the view of what we hear about Appalachia, the opinion that we hear about Appalachia. If you type in Appalachia, you get images of devastating poverty and not the beautiful mountain views. And this is considered a deficit model of understanding health in our region. But so often we don't look under the surface and understand that in Appalachia, we are one of the very few communities that's considered a collectivist community in our individualistic society. We rely on family, on friends, on communities for so much, including our health and our well-being. And that's really the focus of what I want to talk about today, of what that family looks like and how do we harness that strength to enable us to begin to move the needle on these devastating health disparities that I mentioned at the beginning. So first today, I'm going to talk about kind of a theoretical or my overall view of how I understand family and health disparities. And then I'm going to move into some research that me and some teams have been doing here at the hospital and over at UTK. And then finally, how some of that research is funneling into some really excited intervention work. So let's start with families and what that means. So the big model that I tend to use is called the biobehavioral family model. And it starts off with family emotional climate. And family emotional climate is thought of as this balance between support and negativity in a family environment. It's not only support that is critical, or the absence or type of strain that is there, but that balance between the two that leads to disease activity is what biobehavioral family model calls it. And this can be the symptoms, a part of a condition, the chronic condition, the development of a condition, or even more broadly, quality of life markers as well. The biobehavioral family model posits that the way family emotional climate or our family impacts our health is through biobehavioral reactivity. So that is the inflammatory markers or allostatic load in our body that respond to stress, and also depression and anxiety. So if we think about a stress response, it's very typical for our allostatic load or our body stress response. Think of fight or flight to ramp up and then ramp back down. That's normal and very typical. In an environment where our family emotional climate is extremely stressful, our biobehavioral reactivity remains constantly on guard. And constantly high. And if we know anything about inflammatory markers, depression, anxiety, that wear and tear on our body leads to higher and more problematic disease activity in the long term. And this has been substantiated in both adult populations and children populations as well, pediatric populations. But how does this link to health disparities? Well, we know that structural drivers of health are linked to disease activity. And if the structural drivers of health are problematic, then we think of it more as health disparities. So structural drivers of health can impact our health disparities or increase our health disparities through structural factors. So think of access to care, access to healthy food, healthy environments, but also through that same biobehavioral reactivity. So structural drivers of health not only prevent us from accessing the facilities to be able to maintain our health, but also increase our chronic stress that are linked to the same physiological, psychophysiological responses in biobehavioral reactivity. So how are these two linked together? We know that the individual exists within several systems. The system right outside the individual is our family, or as Bronfenbrenner would say, the microsystem, moving to the mesosystem, which might be schools, our exosystem, and then eventually our macrosystem, sorry, which is the legal system and the policies that influence us. And we know that those systems filter down through the other systems to impact the individual. So if we think of this multi-level system, we come up with the adapted biobehavioral family model, where family emotional climate serves as a mediating moderator or a link between structural drivers of health, biobehavioral reactivity, and ultimately health disparities. So how has this been tested? So first, if we think about those structural drivers of health for people of color, African Americans, and discrimination, there's a paper myself and colleagues published about 4 years ago with a African American sample that looked to test that exact model and how family support and strain was linked between discrimination, that's what DIS is, biobehavioral reactivity, and disease activity. And what we found was that discrimination, higher levels of discrimination, actually reduce reports of family support. So it actually harms family if someone experiences the stress of discrimination out in the world. That stress is brought into the home, reducing the level of family support, which, as we would expect in the biobehavioral family model, is then linked to biobehavioral reactivity and then to disease activity. So that discrimination impacts our health, the health outcomes of African Americans through partially worsening their family support. We did not see the same effect with strain. What about diabetes management? We know diabetes is we have really high rates of diabetes in our region. How is family linked to diabetes? This is a paper myself and Dr. Fincham from Florida State did a very long time ago in 2018. And what we found was for the development of diabetes, or what we call diabetes risk, that only our lower income individuals benefited from family support, whereby family support was linked to 80% lower odds of developing diabetes. But the same wasn't true for our middle and upper income individuals who were not accessing government assistance. So that we will see again and again that the importance of that family support is critical for our health outcomes. And another recent study done out of out of the hospital here, this is for patients with diabetic foot ulcers, looking at their what's called the Wi-Fi criteria, which is a marker of severity of the wound. We found that rural individuals presented with worse outcomes, or the stage or the severity of their diabetic wound was worse at diagnosis. So, and we see that also for if the location is also from an economically distressed county as well. So we're seeing that not only does family impact aspects of diabetes, developing diabetes, but also diabetes complications such as diabetic foot ulcers. We see that the location that you live is also impactful. Another disparity that we study here at the hospital with my colleague, Dr. Jill Lloyd, is breast cancer research. So interestingly, this series of studies kind of this study countered what we had seen with diabetes. What we see is people in urban areas are less likely to adhere to their medication compared to those in rural environments. But also, we find that people in rural and isolated areas who don't have food insecurity actually have better outcomes. So it might not just be where you live, rural versus urban, but also the context therein. Do you have access to a primary care provider? Is your community, your neighborhood, experiencing aspects of food insecurity? So it's multi-level in terms of the context in addition to the family. But it's not just impacting your health outcomes. What we also see is that rurality among our breast cancer patients also impacts their reported depression. So level of depression or number of depression symptoms we see throughout the first year of treatment is elevated for our patients if you live in a rural area compared to an urban or suburban area. And when we ask their family members or their caregivers about the strain that they're experiencing or the stress they're experiencing being a caregiver, we find that our patients and caregivers living in rural areas, also the caregivers experience more strain. So the context is not only affecting the mental health of our patients, but also the family members who are caring for our patients as well. And hot off the presses, this was just accepted for publication just under a month ago, kind of delving into understanding pain that breast cancer patients experience, but from both a patient and caregiver perspective. So specifically, we were curious if at presentation, the patients and the caregivers' anxiety and relationship quality that they report, how that was linked to patient pain during the first year of breast cancer treatment. Honestly, very shocking to us, but maybe not shocking to all of our providers out there. We found that caregivers reported anxiety, that bottom line there, was consistently a better indicator of patient's pain compared to the patient's own anxiety. So the patient's anxiety at baseline really only had an effect to about 6 weeks into the treatment. But the caregiver's anxiety at baseline, which is diagnosis, had a far longer reach into treatment affecting patient pain. And that the effect of that reach actually grew in effect sizes from 0.46 to 0.49 at 12 months after diagnosis. We see a similar trend when looking at relationship quality. Specifically, this is marital satisfaction, where higher marital satisfaction is linked to lower pain. This is good news if you truly do like your partner. It is linked to lower pain reports, but not the patients. It was only the caregiver's report of satisfaction that was linked to patient pain at the 6th and the 12-month period. And again, these are rather large effect sizes. So looking at Cohen's D of 0.50 and 0.49, those are considered medium effect sizes, which are quite substantial when we think of the effect of just being satisfied with your partner, how much change that can really occur in your somatic symptoms, how you're experiencing and feeling pain during treatment. So moving to a population, a sample of 100% Appalachian. These were individuals who attended a pop-up medical clinic up and down the south and central regions of Appalachia. We wanted to understand when they came to the clinic what their physical symptoms were, overall health, depression, sleep problems, and their pain at baseline, and how individual social factors and community factors simultaneously influenced all of those, what we're calling health-related quality of life indicators. We see that consistently the number of chronic conditions you have impact all of your outcome symptoms. This, of course, makes sense. Older individuals reported more physical symptoms, poorer overall health, and greater pain when they attended the clinic. We also see that relative income, which is we find it's easier to ask a question about relative income, which is how well are you doing compared to people in your community financially, or people in your state, or people nationally, is a easier way to ask about income than asking their flat out number. People tend to answer this question. We have less missing data, at least. So relative income, so higher, doing better, the perception of you're doing better is linked to better physical, lower number of physical symptoms, lower levels of depression, fewer sleep problems, and pain at baseline as well. Moving to social factors, one thing that we thought was interesting was if your family members, we counted up, they reported on the number of chronic conditions all of their family members had. The more number of chronic conditions your family had, while controlling for the number of conditions that you have, was actually linked to greater depressive symptoms. So the people that you surround yourself with can certainly benefit you and help you out in terms of support, but also can create, strain, not just in terms of maybe conflictual, that's how we oftentimes think of strain, but other factors potentially, like number of conditions, can really impact you as well. The next one, probably not surprising to any of those parents out there, is that parents actually had worse, or non-parents had fewer sleep problems compared to everyone else. When I saw that, I was like, yes, that does make sense. And then moving to community factors, surprisingly in this group, as you'll see the line above what I just highlighted, rurality didn't really impact these health-related quality of lives, especially when controlling for all of these other factors. But what did was access to a hospital, specifically in terms of physical conditions. So the next paper we looked at was, okay, well, what about specifically healthcare utilization? How does our relationship, this is specifically marital quality, link to how we utilize our healthcare if it is available? And this was a sample of just over, I think, like 90 couples that lived here in the Appalachian, like Knox County type region. We oversampled low income couples, so about 50% were under the poverty line. So in this study, we looked at several relationship factors: relationship satisfaction, couple communication, how well do you communicate, and also relationship aggression, which is the activities you engage when you fight. And what we found was that overall, across all of the couples, more relationship aggression during those conflicts was linked to lower utilization of healthcare. But when we dove in, and also, sorry, depressive symptoms, more depressive symptoms meant more healthcare utilization. But when we dove in to look at the effect within each couple, we found that, and these were all heterosexual couples, we found that women's reports of relationship aggression was linked to increases of their male partner's healthcare utilization, but decreases, so lower, of their own healthcare utilization. Men, however, their report of relationship aggression during those conflictual times was not at all linked to their healthcare utilization. And we thought this was really fascinating, especially when considering the family that's wrapping around, or the loved ones that are wrapping around that patient, how different experiences of relationships, or the same experience of relationship, can differentially impact different members of the family. So not just understanding the patient's experience, but also the family member's experience and how those things might come together. So finally, a paper that was published last year, the importance of family relationships for the health of underserved Appalachian families. And this is an application and extension of the biobehavioral family model. What we found, and again, we're looking at family quality, and so this isn't marital relationships, this is just all the family members. Think about all your family members, and overall, what was the quality of those relationships, and understanding how they're linked to depressive symptoms, pain, physical symptoms, number of conditions, and overall perceived health. Family quality was consistently linked to better family quality, was consistently linked to lower depression, pain, physical symptoms, and fewer number of chronic health conditions. But interestingly, we see that rurality, when accounting simultaneously for family quality, was not linked to any of these health and well-being outcomes. The only time that rurality played a role was in number of conditions. This is an interaction term. So what we found for number of conditions, that family support was only important for number of health conditions for people who lived in urban and suburban areas. Otherwise, family quality was linked to depression, pain, and physical symptoms, the same for both rural and non-rural family members. So we have a good amount of evidence supporting this model across general health outcomes or general quality of life measures, number of symptoms, number of chronic conditions, but also deep diving into specific health conditions, looking at symptoms and adherence surrounding breast cancer patients, and diving into some of our research looking at diabetes management, but also complications of diabetes as well. So what does this mean then, taking all of this information and having it inform or apply to our actual patients, so actual human beings? So a couple of important clinical applications takeaways that I have been working with people at the hospital here to implement interventions. One, family support, in particular, compared to strain, may be particularly potent for our under-resourced patients' health. Also, simultaneously focusing on family relationships and the structural drivers of health could be a really potent mix to moving that needle on health disparities. Also, understanding that systemic nature of family caregivers' well-being impacting the patient's health. This is kind of, sometimes it feels like herding cats a little bit, trying to understand these complicated interactions, and may it really require flexible interventions to kind of harness that family power, that family support, or work to mitigate that strain that might be causing or exacerbating symptoms. I think also it's clear that we do need to target mental health as it's linked to physical health disparities as well. So the first intervention that I've been working on with Dr. Lloyd here and Dr. Sarah Woods at University of Texas Southwestern is conquering pain together. This intervention targets breast cancer patients and a family member, whoever they identify as a family support person. The aim is to reduce breast cancer patient pain, specifically those taking AET medications. The intervention includes family communication in addition to dyadic pain coping techniques. And those are pain coping techniques that we teach to both the patient and the family member. Both of these interventions that we're pulling together are evidence-based, have already been substantiated in other literature. So this is the model for the intervention. We know that AET-related pain is present, and then we harness and optimize the relationship support that already exists in this relationship. After all, the family member is willing to show up to the patient's appointment and participate in this intervention. So how can we optimize that existing support? Oftentimes that includes teaching those dyadic pain coping skills. Also, the intervention includes mitigating the dyadic psychological distress. And we do this through thinking that the psychological distress is an indicator of that biobehavioral reactivity. We do that through improving relationship quality, and ultimately that with the aim of reducing AET-related pain. So forgive the ocular trauma of this, but this is just kind of an overview of what the intervention entails. The first is the relationship checkup, and this is to mitigate psychological distress. This is an assessment session and a feedback session, both about 1.5 to 2 hours long, about a 2 weeks apart typically. And of course, like I mentioned, the dyadic pain coping to optimize and harness those supports. So it's 4 sessions. It's the assessment session, like I said, the feedback session, and 2 booster check-ins to see how that feedback session, the skills learned and practiced during that feedback session, how those are going, what maybe barriers we're facing to implement those communication skills, to implementing the skills that they learn. Maybe it was learning how to do a timeout, or speaker listener technique, or identifying patterns of conflict, all of these kind of marriage and family therapy type skills to help them improve their relationship quality, to reduce any of that stress that exacerbates the pain experience. And I wanted to share with you all an example of one of the feedback reports. So that assessment session, you tell the story of your relationship, and you also are asked to identify strengths of your relationship together and also concerns that you might have. So this is, all the names have been changed here, but what they identified more in this example identified was that they had good communication. One of their top 3 strengths was good communication. And then what we give them this written feedback report. And then we also lift up kind of the amazing things that they tend to say, this positive, solution-focused approach of asking them, what do you like most about your relationship? And then in this feedback report, we lift that up for them to see it reflected back to them. So Sally and Mort's ability to communicate effectively have created a safe zone in their relationship that allows both of them to speak their mind and openly ask for support. Sally and Mort clearly have the skills to effectively come together around the problems they face to produce a mutually agreeable solution. Problem-solving skills are key to the health of their marriage and family. To the extent that they can effectively communicate around the issue that divide them, problem-solving will remain a strength in their marriage. So really lifting up what they already do and mapping onto it kind of what we know in the research, and from our point of view, from a marriage and family therapy type of perspective, why this is so fantastic that they have this skill existing. So that's where we kind of start in this positive area, and then we move to what their concern was. And this number 1 concern was cancer reoccurrence. And as you can see in the top of this, we pull out quotes that they said during the assessment session about their concern. But then we also map on what research says about this. So the inevitability of facing illness is common, and coping with that illness can be exhausting. The literature emphasizes that by decreasing negative and enhancing positive ways of relating, families can utilize all of their individual and relational resources to address the demands of medical illness. So we don't necessarily try to make lemon out of lemonade by any means, but we try to give them options to move out of the pattern that maybe they identify as a concern. Then, after identifying the concern and noting what research says about it, we give them options to teach them of how to move forward to enhance their relationship. So we say the point of the relationship checkup is not to make one specific recommendation, since it is rare for one size to fit all. Instead, our approach is to offer you a few options and to discuss other options that might make more sense to you. So this is the 3 options that we presented, Sally and Mort. The final feedback, we would have edited this section down to whatever they chose. But the options were a marriage book option, caregiver personal time option, and we talked them through that, and a communication check option, so checking in about the communication. And then during that feedback session, they would have selected one together and then determined how to move forward and best implement that. So that's Conquering Pain Together very much in a nutshell. The next project that I've been collaborating on is planning together. For those very clever minds out there, you will notice a pattern in how I tend to label these interventions, just to emphasize the family and togetherness. So for this work, I partnered with Doctors Zeit and Maples, and Dr. Ausbau out of UTK, and Dr. Hefner at University of Texas Southwestern. The target is pregnant person and their partner. And the aim is to improve consistent contraceptive use postpartum. It involves an educational workbook, an in-person coaching, and structural drivers of health referral, needs assessment and referral system. So as you can see over here to the right, this is kind of the visual image of how we target or how we've developed this intervention planning together. And I hope you can also see flavors of that adapted biobehavioral family model in this. So first we have the social barriers, so harness existing relationship support, then also including reducing the structural barriers, so tailored community referrals with a warm handoff, and then also a flexible intervention delivery. We see this very much as removing barriers to accessing behavioral health interventions by making it asynchronous or telehealth and in person. So people don't necessarily have to drive all the way down to the hospital in order to access quality behavioral health interventions to help mitigate these health disparities, and ultimately ending in consistent desired contraceptive use. So, oh, there we go. Okay, so this is again an intervention highlighting that in-person or virtual, and there are a few more sessions than the previous one, and of course, because this maps onto a different patient population, attempting to meet their needs, their specific needs. So we have the initial screening. The workbook is an asynchronous workbook, so it's very different than the in-person long interventions. I mean, along kind of more therapeutic interventions from Conquering Pain Together. And then it's followed by what I can call like kind of coaching sessions. So couple contraceptive consultation. Again, this could be in person or virtual, and both members of the couple do meet simultaneously. And then we see the booster check-ins as well. And I wanted to share with you some of the aspects of this workbook that we have developed and hopefully get to implement. We're waiting on some funding to come down from NIH that we're hopeful, fingers crossed, any day now. So first it starts off with really easy, clear to read education about all of the different types of contraceptives that are available. Then we move to kind of interweaving the couple communication aspects. For this project, we specifically use John Gottman. He is a very famous marital researcher from Seattle. 7 Principles of Making Marriage Work, I always like to throw out as a really great read if you're into it. But he coined the phrase, the 4 horsemen of the apocalypse, which are kind of the 4 characteristics or communication patterns that he has observed couples engage in that lead to divorce. So criticism is that first horseman of the apocalypse. And so part of this workbook is teaching them what criticism is, what it looks like, an example, and within the context of contraceptive use is the goal. And then not just what it looks like, but what the antidote to criticism is. And the antidote is a gentle startup and explaining what that is and an example. Then we move to what this looks like when we're in regard to talking about contraceptive use. And then we ask them to engage in these gentle startups, these anecdotes to criticism. So we give them this criticism example. You've never talked to me about birth control before. You always decide yourself. And I don't get a say in talking about how and when we have more kids. You always just do what you want and ignore me and my feelings. So that's an example of a criticism. And then the gentle startup, we ask them to write that in together as a team. Then at the end, they together choose select a contraceptive method that they both would like. And then the coaching session in person kind of re-emphasizes these communication patterns, these healthy communication patterns, these antidotes to the four horsemen, in addition to talking them through the decision that they made or learning about the decision that they made. The next, and this one is definitely still in the works, is healthier together. Partners are doctors Maple here, Dr. Maples, Wolf and Purvis, and Dr. Mitchell up in Michigan. The target is gestational diabetes patients and a support person. And the aim is to improve gestational diabetes self-management, particularly by including that support person. It is an online education program. So again, that idea of trying to remove that barrier of access by providing it either asynchronously, which this is, or through online. And also attempting to not make it terribly dry. So we're developing videos and activities that they can watch and do together to educate both the patient and their support person. Like the previous interventions, it weaves together GDM management and communications skills, couple communication skills, education, because making these decisions, or trying to change your behavior is so hard. It's even harder to change diet and exercise in a family environment that maybe isn't changing, right? They don't have to change how they eat. And it's even harder if you are met with barriers of a communication, an aggressive or critical communication, or people who maybe not through anger or viciousness, but do maybe try and circumvent or try to get you to, it's okay to cheat a little bit. Or what about today? Why don't we just have a little slice of cake today? That's okay. Maybe they feel guilty, right? So looping in that partner or that support person with them so they fully understand everything can really help affect these changes more long term. Here are some topics that we came up with for the online education program. And all of these topics came together using the knowledge of our physicians, the knowledge of marriage and family therapists, and clinical researchers all together, and trying to weave all of our knowledge about what, from a physician standpoint, we want to know, what from a marriage and family therapist that we know would be really good relationship interactions that would help these changes stay more long lasting, and from a researcher's point of view of researcher's point of view of an intervention of how can we make this intervention as potent as possible? How can we deliver this in a way that is effective and that change is long lasting? So here are all of our topics that we've come up with. We're right now in the throes of developing this, but I wanted to give you an example of one of our scripts for our videos. So not only are we coming up with the content, but because we want to deliver it in a way that is easy to consume, we're creating kind of animated videos. And we have a wonderful team of pre-med students and masters and public health students helping us write these scripts. So we give them the content and they kind of come up with these scripts for us to edit. And so this is just an example of Mr. and Mrs. Smith and the narrator and what we eventually, this is still a draft form, of course, but how we want to communicate to a way that is engaging. It's from the standpoint of Mrs. Smith, who has herself been diagnosed with gestational diabetes, telling her story, and the narrator kind of helping tie all of the pieces together. So being mindful of time, here is the last intervention that's in the works that I kind of wanted to talk to you about. And this one is our newest little baby, partner with Dr. Young, Grimsley, Clegg, Goldman, and Liliana. The target is diabetic foot ulcer patients and a support person. The aim is to improve diabetic foot ulcer wound healing and home care. And of course, their intervention would be wound healing and diabetes management education, needs assessment, and social drivers of health referral system. We are, like I said, really in the beginning stages of developing this, and hopeful for some funding to come down so we can really put the rubber to the floor, or whatever that metaphor is. So a wound healing education program for patients and their family member. A provider used screening tool protocol to assess patients' social drivers of health and barriers ultimately to their wound healing, and an effective community referral strategy. So remember, it's not just enough to like know what the issues are. We need to make sure, and it's not also enough to tell the people how to get to those resources. We need what we call a warm handoff, a referral system where we make sure that the person feels as comfortable as possible to utilize those resources. So an effective community referral strategy for those structural barriers, and also psychosocial stressors linked to wound healing. So hopefully you'll hear much more about this project in the future. So that is all I have. Thank you very, very much. Are there any questions?
I have one. I'm curious. Do
Yeah,
you personally do all of the sessions
it's a
for
great
these?
It's a really great question. So for the Healthier Together, the GDM study, and the planning together, the education would go out. I do not. Depending on the intensity of the intervention, the Conquering Pain Together does require a marriage and family therapist to navigate those hard conversations and those complicated techniques. So part of the grants that we get include a marriage and family therapist or a marriage and family therapy trained individual. They're starting a marriage and family therapy school over at the UTK campus. So I'm really excited about trying to get more people locally that have that really critical training in marriage and family therapy. For the planning together, we also plan on having a marriage and family therapist or someone similarly trained in that position to do those coaching sessions. We don't anticipate them being quite as intense as the Conquering Pain Together, just because of the length is not as long. But no, I do not do them all myself. Good question. So
Thank you so much, Dr. Roberson. We really appreciate your expertise and your time today. And so this is recorded and it will be made available later for others to attend to see. But thank you so much. We really
yeah, thank
appreciate
you
it.
all so much. And if you have any questions that pop up as we go along, please feel free to email me or find me somewhere wandering the halls of the hospital.